So without further ado, I'd like to introduce Dr. Heather Barbie, Colonel Barbie from the Walter Reed and USIS Obstetrics and Gynecology Program Director, who will introduce her speakers in the first panel.
Morning. Our first speaker for this panel is going to be Kristen Barnes. Commander Kristen Barnes is Canadian Armed Forces Preventive Medicine and Family Physician who currently works as a Senior Staff Officer to the Surgeon General. One of her principal projects is the renewal of the Canadian Armed Forces Preventative Health Assessment, which will be updated to include a thorough assessment of women's specific health issues.
Button assistance. Is it the red one or the arrow? Okay. Good morning, everyone. While my talk is placed under reproductive health, it's very much a overarching strategic look at a program that we are currently attempting to update. So the topic is how we're going to make women's health a priority in the Canadian Armed Forces Preventive Health Assessment. So right now, Canadian Forces Health Services has a strategic objective to optimize Canadian Armed Forces medical and dental operational readiness. So the first step in us trying to achieve that particular objective is to renew what we call our periodic health assessment, or PHA. So I would like to point out, although I'm going to talk about how we can make women's health a priority, women's health is indeed an integral part of our current PHA program. However, we don't specifically evaluate women's health in our questionnaire, and currently we're unable to capture important women's health data through our process. So I'm just going to give you a brief overview of the CAF female population, how we run our PHAs now, and our proposed changes. So women currently make up 16% of our regular force population. That's only 9,500 women, and 17% of our primary reserve, which is 5,000 people. Women make up 20% of the Navy and the Air Force, and 14% of the Army. And we have a greater percentage who are officers versus our NCMs, or non-commissioned members. So our most recent big Canadian Armed Forces Health Survey, which was done in 2019 but is only being evaluated at the moment, is providing us with a few useful data points with respect to women's health. So we do not have a formal cancer screening program at this time, but we are reassured by the statistics that we've received from the survey. So based on the most recent survey results, 87% of women report that they're up to date with their cervical cancer screening, and 81% of women report that they're up to date with their breast cancer screening. So these percentages are higher than the target for the Canadian population and those reported in the 2017 Canadian Community Health Survey. A few other data points from this particular survey that I thought were useful to mention are that women in our military were more likely than men to use physical, mental, and other healthcare services, so 93% versus 84%. They're more likely to report higher levels of stress, have joint pain, and have a repetitive strain injury. So this is just one smaller piece of many data points that we collect through various research projects, but we will be using this to help shape our PHA renewal process. So what we do currently is a periodic health assessment, and we hope to change that to a preventive health assessment. So right now, every 5 years, members under the age of 40 come in for their PHA, and it's every 2 years for those 40 plus. It's in 2 parts. The first part is a paper-based questionnaire with 27 questions, and none specifically on women's health. This particular questionnaire is relatively dated and is just a brief preventive screen looking at mental health and some health and lifestyle risk factors. So during this medical screen, we look at immunization status, we do anthropometric measurements, vital signs, audiogram, visual screen, and then based on the members' needs, they may have labs or imaging ordered. The part 2 of the PHA requires an in-person appointment with a healthcare provider. So the patient's interviewed to review their medical history, address their current medical concerns. It's also an opportunity to discuss age and sex-appropriate risk factors and behavioral risk factors. And it includes a physical exam, as I've pointed out. We have what we call a medical category system, which is the same as the medical profile system used here in the US. And that also must be updated at each PHA. So the issues we have with the current process are that because of the physical exam component, it's become quite resource intensive for us, and it's no longer evidence-based. And we depend entirely on the healthcare provider to ensure that appropriate preventive services are offered. Our questionnaire is still paper-based and scanned into our electronic health record. So unfortunately, we're missing the opportunity to evaluate the data that it captures. And then unfortunately, our current electronic health record does not have a recall function. So we cannot send out patient reminders for cancer screening. So this is another initiative that we're working on. So the goals of the PHA renewal, as I mentioned before, are to develop a true preventive health assessment. We would like to reduce the need for in-person assessments by a healthcare provider, hence the need to develop a very thorough questionnaire. We want to delink the assignment of the medical category from the process because it's a step that creates an extra clinical and administrative burden on our clinics. And because of the pandemic, we've gotten quite behind and it's affecting our medical readiness. We want to develop a screening questionnaire that is based on scientific evidence. That's going to be based on both the Canadian and US Preventive Services Task Force guidelines. We also want to use questions that are thorough, respectful, and appreciated by our patients. The reason I say this is that there are a couple of questions on our current questionnaire that are controversial. So we want to be sure that we word the questions appropriately. We want to include important women's health related questions. So what we're doing with that respect is we do have a women's health and diversity team that's currently developing a patient questionnaire, and they're currently conducting a scoping review. So we hope to include questions on contraceptive use, pregnancy, fertility, infertility, menopause, urogynecological issues, sexual health, and cancer screening. So this is just a little timeline of our goals for the PHA renewal plan. We stood up our working group in October, and the first thing that we tried to tackle was delinking the PHA from the medical category, which I mentioned earlier. We're close to having that situation settled. And then we've also got kind of a rough draft of our questionnaire, and our working group is meeting later this week to take a look at that. And so we're hoping to have something to pilot in the spring at our clinics on the bases and wings. Importantly as well as we have to develop the IT solutions that are necessary to support this project. We'd like to be able to complete the questionnaire online, and we would like to be able to collect all of the data and be able to utilize it for improving our program. And then finally, hopefully in the summer, we'll update our PHA policy. And then, of course, we have numerous other policies that will need to be changed thereafter that mention this policy within them. So to summarize, the benefits of including women's health specific questions in the CAF PHA questionnaire are that it'll ensure that the important health questions are asked. It'll also ensure that appropriate screening tests take place, and it will aid us in tracking important health indicators in our female CAF members. Thank you for your attention, and I'll be available to answer questions following.
Our next speaker is Lieutenant Colonel Lana Burnett. She's the Army Nurse Corps officer and a certified nurse midwife. She currently serves as the Director of Female Force Readiness and Health at U.S. Army Medical Command, and concurrently serves as a women's health nursing consultant to the Surgeon General of the Army for OB/GYN nurses and nurse midwives. She completed her doctorate of nursing practice at Frontier Nursing University in 2017.
Thank you so much for your kind introduction. I am in uniform, in case there was any question about that. It's an honor to be here. I just want to recognize both the audience here and our virtual audience. It's great to see so many people come together in an effort to support women's health. So I'm proud to be part of this team, and I would be remiss if I didn't recognize you, Carlo, for putting this all together. Your vision for this has really come along, and it's both an honor to collaborate with you and a privilege to call you our friend. So thank you so much. I'm going to focus mostly with a strategic broad brush of what has changed for our entire model in the military healthcare system, which has been a little bit of a change for our services. And I want to recognize Ms. Teresa Hart. She's unable to be here today, but she is our DHA point of the spear, if you will, for all things women's health. And she has done a fantastic job in this DHA transition of bringing all of us subject matter experts from our services to the table. So as you probably well know, the services have transferred healthcare delivery to the Defense Health Agency. And so the Defense Health Agency now has authority, direction, and control over healthcare quality, scope, and cost of care. And that has changed how we are dealing with this from our medical commands. The DHA mission supports the medical readiness of all military personnel, and it supports a ready medical force by providing us with a platform in which all healthcare professionals can obtain training, education, and experience for deployment readiness. As women make up approaching 20% across all components and 17% of the active duty population, addressing the specific needs of women are critical as we see it for readiness and for well-being. So as far as service integration, we have women's health consultants and staff officers from each of the services that are very closely integrated with the Defense Health Agency clinical communities and in a number of action groups to advocate for service-specific readiness in areas both of behavioral health and physical health. We collaborate with the Women's Health Clinical Management Team and the Women's and Infant Clinical Community, and we work together to contribute to readiness and healthcare quality. We do that by leveraging leading practices, evidence-based guidelines, and sharing data. The subject matter experts from the Defense Health Agency and the services collaborate together to sit in groups with the Office of the Undersecretary of Defense, and that enables us to bring subject matter expertise into the areas where we can impact the other social determinants of health. We want to carry the voice of female service members and their family to shape policy and positively impact health and readiness. And finally, we collaborate with the VA to support the continuum of care for service women transitioning into VA healthcare. Again, we share leading practices, evidence-based guidelines, and data-driven efforts to optimize care across the lifespan. We collaborated this year also on the White House blueprint for addressing the maternal health crises released this past June. And the intent of that blueprint is to bring the whole of government approach to bear on the maternal health crisis through a sustained multi-year, multi-agency effort to combat maternal mortality and morbidity and also reduce racial disparities nationwide. And we're going to do that through collaboration and action plans within multiple agencies to improve maternal care. I'd like to focus down on some of the lines of effort that we've been working on in our focus groups. We have been looking for ways to improve readiness by empowering persons to address their needs for access to reproductive health care. And I'm not going to get too granular with this because a couple of our other panel members are going to talk to you about some of the tools that we've been developing together for that. We also have been improving knowledge and healthcare literacy on women's health. So there's updates to the websites and applications that have been developed. We also are reinforcing the primary care provider knowledge and skills to best support women's health. So again, DHA has been integrating with us to get input in developing a women's health provider algorithm that will provide our primary care providers to all of the levels, both physician assistants, advanced practice nurses, medics and corpsmen who may not do women's health on a daily basis, but they need to know how to approach a woman who is presenting to them with a problem and what can be done here and what needs to be a consultation with another healthcare provider. We also have been working in collaborative groups to define some of the high priority issues of readiness to include musculoskeletal injuries, pelvic health, and mental health to develop initiatives in the clinical and non-clinical spaces so that we can promote wellness and self-knowledge. One of the lines of effort that we've been working hard on recently is the same-day walk-in contraceptive service to improve the access to reproductive health care. And as you know, contraception is important for women to be able to not only choose their timing for family planning, but also to manage menstruation. And particularly, we want to make sure that their needs and preferences are addressed in that process. I'm going to call out the value of having surveys which provide us with the insight to the needs and preferences and experiences of women. So there's information that we can gather from surveys that we are missing in the healthcare space if we rely solely on the data that's within our healthcare systems. So we had valuable information from the RAND Corporation's Women's Reproductive Health Survey that was really a strong forcing function behind our walk-in contraceptive service plan. In that survey, they found that more than 1 in 3, or 37% of active duty females with a prior year pregnancy reported that the pregnancy was unintended. This extrapolated to nearly 6% of active duty women that were going to experience an unintended pregnancy per year in comparison to the US general population of about 4.5%. And more than half of the women with these unintended pregnancies said that they were not using contraception. Those who were using contraception indicated that either the method failed or they were using the method inconsistently. Less than 50% of active duty women were using contraception that was considered to be a highly effective method. So looking at the same-day contraceptive service, it was an easy decision to say, we need to make this more readily available to women, and we need to get it to them in a way that makes it more convenient for them to come. The other thing that we realized was at many of our locations, women would have to make multiple appointments to receive counseling plus a procedure or counseling plus the contraceptive method that they preferred. And you can imagine in a span of a few weeks of less effective contraception that definitely has an impact to unintended pregnancy rates. So we did have evidence from the Navy on the successful implementation of same-day contraceptive counseling and procedures. You may have read about those called PINK clinics. And that was great evidence for helping decrease unintended pregnancy rates and increasing the use of long-acting reversible contraceptives, which we recognize as highly effective forms of birth control. So that was great information and a framework for us to work through the implementation of a walk-in contraceptive service. So the DHA recently published policy requiring military treatment facilities to stand up this contraceptive service, and efforts are continuing with that. The clinical management team has provided robust support, having meetings available to our champions twice a week to help address questions and challenges that people are experiencing on ground so that they can help work with them over time. I am going to turn over the mic to the next colleague behind me, and then I will definitely be happy to address any questions that y'all have.
Our next speaker is Julie Greaves. Julie is the principal physiologist for the UK Army. She heads up the Women in Ground Close Combat Research Program and has special interests in female physiology and bone biology. She holds an honorary professorship at UCL and is the chair of the new NATO ET panel on optimizing menstrual health and servicemen.
So good morning, everybody. I would firstly, I feel really honoured to probably be the token Brit on the panel today. So thank you for welcoming me. And secondly, I think it's just to share the virtual and kind of physical room with those who are very, very passionate about the same topic that I've spent a big chunk of my time on over the last kind of big part of my career, but notably over the last few years. So I'm going to take a little bit of a different approach here. I'm going to really take a bit of a deeper dive into the research, into the data and evidence that we have on menstrual health, or as I would really typically like to refer it as, is the fifth vital sign of health for women. And just to add a little bit of historical context here is back in 2014-15, when we were really in the following footsteps of both the US and Australia, with considering opening up the ground close combat roles to women. As the kind of frontline command army physiologist, I was asked specifically about what the potential health risks were for women in GCC roles. When I say I was asked, I proposed what those potential risks might be because it was excluded as part of that review. So we brought it to the table what the through career health risks would be for women performing the more arduous roles. And my first reaction, having spent my whole career conducting research on women, women's health, women's performance, but the reports and the output never really landed. There was never interest in any of the research that really focused on a minority population, which was fine at the time because I was able to drag up 15 years worth of data to present to the ministers in 2014-15, but really kind of highlighting that what we do experience, and we still do, is a gender data gap in research, and not the observational data we've heard earlier, that we have lots of observational data, epidemiology data, because women form part, obviously, of the military population. But some of the work that we've done and the work that we published, and specifically on musculoskeletal health, is that very few women are included in interventional studies. So when it comes to the higher levels of evidence that we really need to make an effect and to have evidence-based interventions, women are excluded. And that's a really, really important thing to kind of hit home on, because we are really just the tip of the iceberg at closing that gender data gap. So we've had a dedicated research program, and it's all women because we've only just really had enough women in GCC roles to start monitoring their health. So we've been looking at our legacy workforce and comparing it with men. Obviously, it's about where the risks sit with the whole of our population. And the kind of the themes that I focused on in 2014-15. It's really hard to choose what we were going to report on to support a ministerial decision when there was so much to do. So the specific focus that we had, and I had a really good understanding of where some of those key knowledge gaps were to support this ministerial decision, looking from the kind of the left top part of the panel, was on mental health, particularly sleep, psychological stress, mental health, physical performance. Traditionally, we do a lot of kind of training, more kind of endurance-based, but we should be training women, probably for all roles to be fair, but particularly in GCC roles, for strength. Strength is a really important fitness component for many military tasks, and yet it's never been a really traditional component of physical training. So what trainings would be optimal for women in GCC roles? Postpartum women, I'd already had data showing an increased risk of illness and injury postpartum. What happens when we put 40, 50 kilos on women in terms of load carriage? What's the impact of that? Feeding, so lots of different components of performance. And then we look at the bottom right panel, musculoskeletal health. I've got particular interest in bone biology, bone stress injuries. What's the impact of estrogen or hypoestrogenemia, energy balance, and some of those pharmacological interventions for bone stress healing. And then finally, it was reproductive health. So it was reproductive health in terms of the interaction between menstrual health, contraceptive use, and bone, but also infertility. So we've done all of this kind of research over the last, and we obviously weren't derailed by COVID, but we were significantly delayed. So we have a lot of evidence that we'll be delivering in the next few months. And I would still say even now that we are probably just tip of the iceberg. And a room of experts, obviously, women perform majority of the military service during their reproductive years. There's some, obviously, periods of pregnancy. And then towards the tail end of a career for many, it's also the menopause. So that's the continuum. So menstrual health isn't just a monthly cycle, it's the continuum, and is hormone health through career. And I think that's what we really need to particularly focus on, is the hormone health through career. We know that contraceptive use is very popular. We've got epidemiology data here from our 3 services, a kind of 30% response rate showing that contraceptive use is very popular. 60% of our women use some form of hormonal contraceptives. And notwithstanding, many use it to prevent pregnancy, and that's a really important consideration, clearly, and for medical reasons, a really important consideration when it does come to kind of making informed decisions. But 57% of women use them purposely to suppress menstruation. And I think that's the population and the issue that I really particularly want to draw upon today. I think it's important to just make one observation with contraceptives is that, and I think it's the only data that I've seen, and we're just about to publish these data, that the contraceptive pill was the most popular form of contraceptive that our women took, but also the Mirena coil. 30-40% of women chose to use the Mirena coil, showing that suppressing menstruation through the LARC methods is also a very popular decision. I'm not going to focus on menstrual cycles. Everybody in this room could probably describe this much better than I can. But the one point I just want to make on this slide is that when we refer to the menstrual cycle and frequency of periods and flow of periods, the one single event that is probably critical in terms of performance and musculoskeletal health is ovulation. So when we talk about menstrual health, it's not just about the regularity of bleeding, it's about are women ovulating or not. And that's really difficult, clearly, to track and to monitor. And I'll come on to that a bit later about how we need to be empowering our women to be able to really remotely monitor their health. And another really kind of important point I just want to raise here as well is that, and I'll be discussing kind of the role of energy on menstrual health in a moment, but clearly the reproductive axis is controlled by the higher centers of the brain. So we really need to be thinking about the psychological stresses and sleep disruptions when it comes to discussing menstrual health. So I've got this great infographic that we've kind of used internally just to kind of demonstrate specifically the unique stresses that women experience and men to some extent during military service, and notably during periods of hard training, basic training, pre-deployment training, on operations and promotional courses. And that's reduced food availability, time pressure to eat, limited food choices, disruptions to appetite, and traumatic life events, particularly pre-enlistment, and psychological stress, which is very inherent with many of the tasks that our military personnel are required to undertake. And sleep deprivation or disruption, I think we need to come up with a term that's really kind of recognised here, because there's lots of different ways that sleep can be disturbed. And then the individual, it kind of impacts the socioeconomic status, contraceptive use, age, and then that kind of androgenized phenotype. There's lots of factors, environmentally and individually, which disturbs the reproductive axis. And more importantly, the HPG, the hypothalamic pituitary gonadal axis, is very closely kind of located with the adrenal axis, and the two can really kind of interact. And I think we need to recognize that. And I do feel with the athlete literature, that component of the axis is often ignored, and why we can't always just translate findings from female athletes to our professional soldiers. I've got here bone, mainly because it's one of my passions, but because it's probably where the strongest evidence sits in terms of what impact disturbed HPG axis has on the body. So you might kind of be aware of the female athlete triad. It's been popularized since the 90s, first coined by the American College of Sports Medicine, and it's been updated because it's a continuum. It's not just those really kind of severe clinical endpoints. And this is that association about the empty tank. It could be due to eating disorders, or just simply due to the demands of military training that has a direct effect on the reproductive axis. In menstrual cycles, they're very energetic, and when the body is trying to survive, menstrual cycle in survival mode is the first thing that's obviously downregulated. And is that interaction with skeletal health. So this is where the evidence in the literature largely sits, and there's strong evidence. And we wanted to explore this, is that actually, does this triad exist with our women, or is it more than the triad? And that's really particularly important when it comes to the early exposures to military training, where stress fracture rates in women are 2 to 3-fold higher. But then when we really dig deeper, the hip fractures are 10-fold higher. So if we generalize and just discuss all MSKI, we're really missing the nuances where we can have targeted intervention. I just want to pay a little bit of lip service to REDS, the relative energy deficiency in sport, because there's a lot more kind of adverse outcomes beyond bone that are really being kind of popularized again in the athlete population, and rightly so. But I think if we're really quite kind of rigid, and we've published a paper here which is looking at all these different kind of where the evidence sits in terms of these adverse effects. But if we just look at this as a clinical diagnosis of energy deficiency, which happens pretty much to all soldiers who undertake really arduous training, then we are probably really going to miss a trick with how we can really optimize menstrual health. I'm just going to present a little bit of data, because this was a superb study that we first performed with our officer cadets. And at the time, in 15-16, it was the only course where men and women trained together, and where women trained to infantry standards. And as the officer cadets doing the commissioner course is 44 weeks long. There's 3 weeks of 14-week terms, and separated by 3 weeks of recess. And we did a huge amount of measurements on women not taking contraceptives and a small population who were taking contraceptives, and we measured their energy intake and their energy expenditure through gold standard methods. So energy out is the red bars here, and the energy in is the green bars. And as you can see, in term 1, the junior term, there's not too much of a disparity in energy balance here, but then a lot of this was taken on camp. When we went out into the field, which intermediate term is really largely field-based, there were significant deficits in energy that just simply weren't being met by energy intake, just because it's challenging being out in the field and consuming, as you can see on that kind of top bar, up to 4,000 kilocalories per day for women. Very difficult logistically to carry that food and to eat that amount of volume of food during simulated field conditions or simulated operational conditions. So we would kind of speculate here that actually the biggest risk for energy deficiencies in the field, not so much eating out of the canteen, and that really kind of largely was restored by the senior term. And then if you have a look at the bottom, this is measured. These are gene active physical activity levels. They're really strong agreement with W-level water, and you can see more of a cyclical effect in camp of those physical activity levels, and also the cadets are sleeping. Okay, they're not sleeping much, but they are sleeping. But in the field, it's constant 24-hour activity. So the risk in terms of the arduous nature of training is really apparent in field-based activities. And we measured sleep, and I think it's important to kind of observe here, because I think it's very characteristic of military populations, is that throughout the whole of the course, typically the average hours, a number of sleep was about 5 hours a night. Sometimes it was less, sometimes it was more. So chronically kind of exposed to poor sleep hygiene. So I'm just going to go on. I've got not long actually to talk about this, but we did for the very first time, I believe, in these environments, infused with ganadorelin and synacthin, just to really see what the brain responses were to understand the central function, dynamic function of both the reproductive axis and adrenal axis. And we demonstrated in very low numbers, but these were very, very difficult studies, that actually 2/3 of women were anovulatory and 1/3 were amenorrheic. So women were still menstruating, 1/3, 2/3 of women were still menstruating, but most of them had stopped ovulating. So if we just track by periods and not by measuring ovulation, we're not really understanding menstrual health effectively. We didn't see any indication of psychological downregulation, but there was evidence of hypercortisolemia throughout training. I'm just going to make a really important point here, though, because we also did concomitant measurements of bone. Tibial bone increased beautifully over the whole course of training. There was a decrease in the volumetric BMD in that first term, but that could be the bone was also growing, so it was probably a bit of a catch-up for bone to mineralize. And so the propensity to stress factors early in training might be more to do with the rapid kind of increase in bone size that then needs to be refilled with mineralized bone. So we've got a lot more work to do with propensity to stress fracture risk, but we didn't really show any effect of the bone due to those periods of energy deficit. I think important observation, though, when we also looked at women undertaking the Antarctic unsupported expedition a few years ago, again, the tibia bone, in spite of 12 kilogram body mass loss, still protected their tibial strength, their strength of both their ultradistal and distal third, but in both the cadets and also in these soldiers during the Antarctic expedition, lost up to 3% of their bone mass from their axial skeleton. So there's something going on there that we just really need to keep an eye on and understand more about their bone health through career. Just really quickly here, we've done a large epidemiology survey. This was a purpose-designed survey with using eating disorder questionnaires, validated questionnaires, psychological questionnaires, and this was to really understand what's the prevalence of menstrual dysfunction in our pupils. So again, we had over 3,000 women respond. The participant flows on the left-hand side. If I just go straight over to the data on the right-hand side, that top panel, the outer circle is the prevalence of amenorrhea in the last 12 months. The middle panel or the middle circle is the history of ever having menstrual disturbances, and then the middle part is delayed menarche. So we report in our population that 18% of women have suffered some form of menstrual disturbance, that's Oligo or amenorrhea, over the last 12 months, and 25%, a quarter of our population, have suffered menstrual disturbance over the course of their career. And the risk factors for menstrual disturbance in what was actually a really thorough questionnaire-based study was sleeping for less than 5 hours compared to sleeping for greater than 8 hours. It was being on field exercise for more than 10 days a year compared with no field exercise. And it was common mental disorders, like anxiety and depression, as well as eating disorders. So it's complex. This is a multi-stressor environment which affects menstrual health and not purely down to energy intake. So I would just kind of summarize here. If we were to extend the triad was relevant to our women, it must include psychological health and it must include sleep. I think we've got a lot more research, I think, to do to really kind of take this forward. And my last two slides, in terms of what do we do next and how do we support our women? And I mean, this is not an exhaustive list by any means, but education and practical support. And this is not just educating our women, it's educating male colleagues, seniors, and peers, as well as women on menstrual health and providing practical support. And we have some initiatives, there's lots of work that's gone on women's health, and this is really just a snapshot. And a Service Women's Health Handbook was published just last year with advice on how to manage menstrual health in the field hygiene, and also an initiative to take out a black box into the field in austere environments where there is replacement uniform and there are menstrual products there that women can tap into. The screening tool for clinicians to be able to predict those at risk, We're doing some work on tracking at the moment. So this is track ovulation. We're using wearables, wrist and finger mounted in our Empower study to assess if we can validate ovulation during arduous training in our women. But this is really underpinned by a cultural change, because the issue with women only being 10% of the population and to being still strangely a taboo topic, even though it's just fascinating biology, is that nobody wants to talk about. And I published an article on this, but it's one publication is not really going to induce a behaviour change in defence. And I'm just going to conclude with, there is going to be kind of a task force to try and kind of pull all this together. And I talk about end state. I think I've already had a vision that we want to optimise menstrual health and service women. So the NATO panel haven't sat yet, but I do kind of put a pledge out there that if anybody is interested in being a part of this panel, we have an ET for this year to scope. And this is a really good example of where we can collaborate and where we can make a difference. And that's certainly the end state for as far as I'm concerned. And I really feel that I've got some beady eyes on me, so I didn't even look at my time, so I do apologise.
Our final speaker for this panel is Dr. Catherine Whitcop. She's the Associate Dean for Medical Education and Professor of Preventive Medicine and Gynecologic Surgery and Obstetrics at the Uniformed Services University. While on active duty, Colonel retired Whitcop served as the Chief of Training Health at the U.S. Air Force Academy and as the Preventative Medicine Consultant to the Air Force Surgeon General. Prior to retirement from the Air Force in 2019, she served as the Program Director for the Preventative Medicine Residency at USU. Throughout her career, Dr. Whitcop has worked to advance the optimization of women's health, with particular interest in shared decision-making and empowerment of patients through digital tools, the focus of her recent PhD dissertation. She is a fellow of both ACPM and ACOG and currently serves as the chair of the Multidisciplinary Steering Committee for Women's Preventative Services Initiative, otherwise known as WPSI.
Good morning, and thank you for the opportunity to present to this truly international community. The opinions and assertions I'm presenting are my own, and I have no conflicts of interest to disclose. This is what I'll be covering in the next 10 minutes. Essentially, a few digital tools, and you've heard about each of these already this morning, that have been developed to optimize the health of military women by empowering the patient and equipping the provider. But first, the why. This slide shows the why. Women in the military are now able to join just about every career field and go just about anywhere that the DoD goes. This requires us to think more about some of the challenges women may face when they deploy, especially to austere locations. While women may not face any difficulties, and we hope they don't, there are many who will. And when on a ship or in a downrange situation, for example, the solutions available to women back home may not apply. We just heard this morning from Lieutenant General Crossland about personal issues with fibroids and menorrhagia. That's just one example of some of the challenges women may face. We also recognize that most women serve in the military during their reproductive years. I love this drawing, third one over, by then Air Force Senior Airman Tammy Ramsauer, because it celebrates pregnancy among military women. We want to ensure that women are empowered to plan if and when they want to have children, and this is absolutely compatible with the military career. The question earlier this morning about fertility services is also critical. And though outside the scope of this talk, I wanted to reassure folks that there are many colleagues within the military health system who are working on this topic and ensuring these services to women as well. The graph below the drawing shows some contraceptive utilization rates that were published several years ago among military women. And I show this to show that we are tracking this now. There was a question earlier about how we're tracking our contraception. And we want to ensure that access to the full range of contraceptive methods is available for all service women. And many of the things I mentioned and that you heard about earlier this morning were covered in the recent Defense Health Board report on active duty healthcare services. Really comprehensive and enlightening report. I'd recommend folks take a look at that. So now the how. I'm going to discuss 3 tools that were developed as solutions to some of these challenges that service women face. So over the past decade or so, we've come to realize that unintended pregnancy rates among military women were unacceptably high, and that gynecologic conditions often hindered optimal performance of women in their military duties. We also have come to recognize the availability of highly effective contraceptive methods that also have a vast array of non-contraceptive benefits. There was, however, a gap in that many service women had incomplete education, knowledge, and access to contraceptive methods. So the first digital solution I'm going to discuss today is a mobile app contraceptive decision aid called Decide and Be Ready. First, what is a decision aid? Decision aids are tools that can help with shared decision making, which is a collaborative process in which patients and providers make healthcare decisions together, considering the patient's values and preferences, as well as the applicable scientific evidence. Shared decision making requires individuals to have information or knowledge and feel empowered to take action and have agency to do so. Decision aids are designed to facilitate that for patients. I want to emphasize that decision aids are not meant to replace that important critical healthcare interaction with providers, but it's meant to help providers and patients make the best decisions possible when facing these decisions. Decide and Be Ready was designed to facilitate shared decision-making around contraceptive decision-making for military women. It was developed as a collaboration between Uniformed Services University, the University of California, San Francisco, and the Connected Health branch of the DHA, with funding from the USU Defense Health Horizons program. It is released in 2019 and is free to all on App Store or Google Play. I want to take the time to mention that why we selected a mobile app as the platform. Benefits of a mobile application are that it's personal, private, available to all, and can be used in deployed settings. I just learned this morning, however, that this is not available to our Canadian colleagues and some of our other international colleagues. So I'm going to take that back for action to our team at DHA to see if we can make this more accessible to our international colleagues. This slide shows all the features in a table of a decision aid and of this decision aid in particular, but I'm going to go through each of these using screenshots from the app, and I'm actually glad I'm doing this for those of you who haven't been able to actually access the app. So first, an educational session, things to think about. This lists the areas that are covered, and I'm going to go through each of these, again, with just some examples from screenshots. So effectiveness, how well does it work? Decision aids are unique in that they present the data in a way that's really understandable to anyone. And I think both sometimes rates, effectiveness rates and the like can be complicated, certainly for our patients, even for some of our providers to be able to understand and explain. So this is how they're pictorially represented on the app. Mode of use, how do I use it? Each one of the methods that's covered in the app is linked to a separate screen where you can actually see how it's used. We do include the male condom and vasectomy. Those are the only methods that are covered that males use. Frequency of administration, how often do I have to remember it? This demonstrates the different methods. For those of you who do use Decide and Be Ready, we're in the process of updating. Several of the lengths of use have changed in the past year or so, and so those will be updated in the newest version. Side effects, are there any side effects? What are the non-contraceptive benefits? This is really important for the reasons I mentioned earlier. Contraceptive methods are used not only for preventing pregnancy, but for a number of GYN conditions. And so some of these, the good stuff, for example, are things that women may use to treat gynecologic conditions, may use for menstrual suppression. And this app just gives an introduction to women about that. Return to fertility. A lot of women are concerned if they're on a contraceptive method, how quickly can they become pregnant afterwards? Birth control after having a baby or postpartum methods and which ones are best to use postpartum are also covered. This is what's most unique about Decide and Be Ready compared to anything available outside of our military setting. These are important considerations for military. We talk about menstrual suppression. We talk about what if I'm deploying, which methods have unique characteristics that you may want to consider before you deploy. Info quickies, these are little information pieces. One thing I want to highlight, fertility awareness. We're actually expanding that within our next version of our app. We got a lot of feedback from many of our users who wanted to have a little more information about fertility awareness methods, so that'll be included in the next version. And then this is what's most unique about a decision aid that makes it different from just a simply educational app. It allows a user to indicate preference for the method characteristics as described in those educational components. So the app will ask the patient a series of questions that the patient answers. And then at the conclusion, the app will then, using an algorithm, mention the methods that are most aligned with how the patient answered all these questions. There's also a question about contraindications, so asking about, for example, migraines, migraine headaches, to identify eligibility or ineligibility for certain methods. And again, this doesn't replace the provider. Those are discussions that are really important to have with the provider. And then finally, the app will, like I said, display those methods that are most aligned with what the patient's preferences are and their values around contraceptive methods. It then allows the user to then navigate and click on these individual methods and then go back to some of the other parts of the app. This method chooser, it allows the user to select two methods and look at them side by side, comparing characteristics such as effectiveness, mode, frequency of use, etc. There's an area for the individual to type notes into the app. That's a native part of the app. And then finally, there is a display at the end that allows the user to print out their method preferences, relevant medical history, questions to ask their healthcare provider, methods of most interest. And the user can then share this display and or print out with the display with their healthcare provider when they go in for their discussion. And this is just a shot of all of this. So the iOS version can be accessed at the App Store, the Android version on Google Play. You can find it using search terms such as decide, be ready, military birth control, any number of search terms. I wanted to share some outcomes. As mentioned earlier, this app was highlighted as a best practice by the Defense Health Board in their report, and they're really encouraging using it. We're really encouraging using it, especially in the setting of the walk-in contraceptive clinics. If a patient has gone through this app prior to showing up for the walk-in contraceptive clinic, that process can be much more efficient. The patient's better informed, and they can have that discussion with their provider. We've done a few studies looking at the app. My personal area of interest is in shared decision making and the impact on patient agency and facilitating that shared decision making. These are a couple of papers we've published. And there are a number of other studies. Some of our medical students have done studies related to the app. Some folks out in the rest of the MHS have as well. So please continue to look for those. Okay, so moving to the deployment readiness education for service women handbook and app. As I mentioned earlier, women are serving an increasing array of fields and deployment settings. We've recognized that health-related deployment information is often lacking or difficult to access. The DRESS handbook and mobile app were developed in response to that gap. This was what Lieutenant General Crossland had mentioned earlier. So this was originally the handbook, and it's now been transformed into an app. And I'm going to just go very quickly give you a little tour of the app. This is where it can be found, mobile.health.mil. There's actually instructions on how to download it then onto your phone. There's 3 different phases that are covered, so preparing for deployment. And I'm just going to highlight a few of these, few of the things that are covered. So for example, if you were to click on contraception or contraceptive walk-in clinics, you'll get information about contraception. I love the fact it links to our Decide and Be Ready. We really want to be collaborative and not be working in silos with these apps and these digital tools. This is information about walk-in clinics, where they can be found. That number of locations is expanding, as you heard about earlier. Pre-deployment checklists. I love the fact that the app contains these checklists. For example, family care plan. It actually has the checklist right there on the app. During deployment, again, as I mentioned before, there's several times that women may not have access to a lot of information when they're in a deployed setting. Having this available on their mobile devices is really helpful. So for example, mental health care, your clearance and confidentiality, information around privacy, around mental health concerns. Physical health, so hydration, how a woman can ensure she's adequately hydrated when deployed. Again, I'm just highlighting a few things. There's a lot more in there. Please go into the app later and check it out. Someone asked earlier about infertility, healthcare benefits and coverage. So post-deployment, we don't often think about what folks face post-deployment. So there's information about infertility healthcare. Another thing that I found fascinating was there's a section on VA women's transition training. So really covers a gamut of things that women may be thinking about when they return home. And then this is how to access it. Okay, finally, the third challenge I'm going to address today is that service women may often be seen by operational providers who may not have a lot of experience with women's health conditions. There's a lack of helpful point of care resources to aid healthcare providers in triaging common women's health conditions in remote settings. So our colleagues in the Navy stepped up and designed a series of tools called the Women's Health Provider Treatment Algorithms. These algorithms can currently be accessed via a CAC-enabled desktop, but fortunately these two will be available in the near future. I don't know how near, but in the future through a mobile app platform. And again, I'm just going to share with you a couple of the screenshots from the desktop version, but I'm looking forward to this also being available on an app in the future. So for example, irregular bleeding. This provides a simple description of normal menstrual patterns, and then offers the provider, the clinician, the person seeing the patient, who may not, frequently see patients with irregular bleeding, a series of questions they ask the patient and then ask themselves, and then it follows through, and they can actually look at potential further evaluation and treatment. This also covers, we're really encouraging women, if they would like, to use contraceptive methods during deployment. However, sometimes there are side effects that come up, and some providers may not be comfortable dealing with these side effects. So these cover, for example, oral contraceptive associated bleeding or IUD associated bleeding. STIs are covered in another algorithm. I'm just going to click through this quickly. Okay, so first of all, I do want to say that there are a multitude of people who contributed to the development of those apps. I was only personally involved with Decide and Be Ready, but there are a number of people who are involved. So I'm speaking on behalf of them. I'm not claiming any credit for any of those apps, and I just want to thank them because I think these tools are going to be really helpful for our service women moving forward. I'd also like to thank you all for the opportunity to present, and I'm happy to take any questions, I guess, with the panel.
If anyone has any questions, please feel free to come to one of the microphones to ask. Yes.
Okay. So, Marc Bilodeau, Surgeon General for Canada. For those of you who haven't heard me this morning. So, you mentioned a lot about the importance of surveying our women in uniform. And there's also a component of, individual assessment through the periodic health assessments that we do. I'm wondering if you think it would be a good idea to try to standardize our approach there between countries. Thank you.
I do.
Whole thing. That's how that's going to work. So I think it would be valuable. The challenge is aligning our periodic health assessment. So I said to her right away, we need to talk because last year we submitted new questions to be used for the women's health portion of our periodic health assessment. Our periodic health assessment was a little bit different. We do it annually, and it is linked in with the task force guidelines, but also we recognized we were in the same boat. Some of the questions that we were asking were controversial and not really getting after. For example, and I may not have the words exactly verbatim off of the tool that we had or that we're using now, but the Part 1 questionnaire says something to the effect of, are you interested in birth control? There's no information on there that tells the soldier that birth control methods can be used to prevent pregnancy and to control menstrual bleeding. Would you be interested in talking about it? So there just were things missing that we thought needed improvement. So I'm excited to collaborate on that and see what each other is doing. And I think there's definitely more room for collaboration, sir. Thanks for the question.
I have some online questions. So from Janice K, the question is, has menstrual cycle tracking been taken into consideration when considering physical training / readiness? hormonal fluctuations have a huge impact on physical training?
Could you just repeat that last bit again, please? I caught the first chunk of that.
The last part is more of a statement that hormonal fluctuations have a huge impact on physical training.
I think if I just deal with the latter one, there's been a systematic review. I'm going to have to do the same as you. It's a heavy little number. There's no strong evidence that the menstrual cycle affects physical performance. There's a systematic review that was published just in the last year to show that. It's not to say that there's no effect. It's just there's more research really needs to be done to prove if it is or isn't. But to date, there's no strong evidence that that is the case. I think importantly, it's important to promote menstrual health tracking, but I think we can actually do better about how we can do that more effectively as well. But I think we just need to myth bust a little bit, because I come across that comment a lot about physical performance and the reproductive hormone effects, and we just need to probably just be a little bit cautious that that women are not really promoting or being encouraged to train around their menstrual cycle.
We have a couple questions.
Hi there. I have a couple questions. What are the anthropometrics you're including in the PHA? Have they changed from what they were previously?
For the Canadian forces, they've been the same for many, many years, and it's basically height, weight, BMI, waist circumference.
Okay, so you are collecting waist circumference in
Right,
PHA.
but we have not evaluated what's going to be encompassed in our new PHA. We're still working those pieces out.
Okay. I'd be really interested in that conversation, especially at the menopausal period, because this is when women have to worry more about cardiovascular disease, which is still the #1 killer. And I feel like sometimes they don't think about that until menopause, when already waist circumference might be outside of healthy guidelines, which I believe is the best predictor for cardiovascular disease and all-cause morbidity and mortality, according to the Cooper Institute. So that'd be something I would love to see us, Canada, and frankly everyone focus on, is encouraging those anthropometrics to be used earlier to prepare women for menopause and now entering a phase where we don't have that protection against cardiovascular disease.
Thanks. I'll talk to you later.
Good morning. Thank you. Lynn Van Eersel. I'm one of the preventive medicine residents at USU. Professor Greaves, love that you use the term the fifth vital sign for menstrual health. I think that's fantastic. Your work is really interesting to me, and I'm going to dig more into it just to learn more. And then Dr. Whitcup, I was thrilled to see that fertility awareness is actually being implemented into the app. I was actually really surprised and just curious where the impetus came from to include that.
So it was mentioned even in the first version of the app, but it just had that very brief information piece. The reason it wasn't included, I'll start by saying why it wasn't included initially in the first version in terms of the algorithm, where all these questions are asked, is because the evidence base for fertility awareness methods, because there's several different or many different kinds of fertility awareness methods, the evidence base around effectiveness, in terms of what exactly the effectiveness is, et cetera. We got, actually, it was during user testing, both pre-deployment, pre-dissemination user testing of the app, and then since the app's been out, we get feedback periodically from our users, and we've gotten a lot of questions about why it's not included, why there's not more detail included. The methods that are included in the algorithm are all pharmacologic or methods that can be prescribed. The fertility awareness methods was in a slightly different category. However, as you know, there's now an FDA-approved fertility awareness method app, and so the new version, the updated version, Decide and Be Ready, will actually include some of that, the effectiveness rates from that particular method and some of the other methods. So it was in response to feedback from service members, and I would encourage, the app can be updated. The DHA now is currently maintaining the app, and we're able to do updates as needed. And so we want to hear from folks like what they'd like to hear more about. So that was one of the reasons that we've expanded that. And quite honestly, I think a lot of providers don't feel comfortable always talking about fertility awareness methods. And I think sometimes this app can actually be very helpful for our, especially colleagues and providers who aren't as familiar with some of the methods. I actually encourage our medical students to go through the app, our residents, et cetera, from and some of our other providers.
Thanks so much.
One last question.
This is for Dr. Greaves. Ma'am, so I spent a lot of time working at NASA, and they did a lot of work, both in males and females, on bone mineral density changes with spaceflight. And there was a couple interesting things that they saw, that bone mineral density changes in and of themselves are not the most accurate predictor of what we were looking for as end-state injuries or cytoarchitectural changes. And in particular, very little was on tibia, it was more on axial, hips, and other places. Can you speak a little bit more to the end organ dysfunction and the architectural changes that you see with different sites and the relevance to the military?
There you go. Yeah, really lovely question. And I think this is kind of really important, because when we talk about bone health, I think it's important that we are more specific about what we want to hear about, because bone health for the military is really largely in the shorter term about preventing bone stress injuries. So it's those weight-bearing sites we are particularly interested in, what's happening at the tibia and the hip. But then what we need to really understand is what's the bone health over the course of a career. And if we're seeing these, we hypothesize really what's happening is that calcium intake is insufficient, and to support the growing skeleton at the weight-bearing side is basically robbing the spine to obviously redistribute the calcium. And we are looking at that at the moment, that if we provide more calcium, are we protecting the spine, as well as obviously supporting the growth of the weight-bearing bones. So I think that when we look at bone health, we need to be comprehensive in our assessment. We need to be thinking what our short-term purposes are. We're looking at bone health, and we need to be looking at our longer term, because we have really kind of a dearth of data on what the bone health of our population is through career, because osteoporosis is a silent disease. It's not until people fracture do we know that there's actually something wrong, and that could be once they've left service. So I think we just really need to understand, to be able to look after our people through the whole of their career. We're not really too worried about bones of the axial skeleton, of the appendicular skeleton, and we've seen some remarkable bone growth, given that these are post-pubescent people. Military training is very osteogenic, but our concern is about the axial skeleton and the strategies that we need to use through career to protect that skeleton in men and women. Did I answer your question? Because I could talk about bone all day, so I probably just...
Thank you.